this interesting session talking about transforming the digital, the healthcare through digital health. On our panel today, we have 5 panelists, and those are Mr. Mohamed Semakula. Please welcome. We have Dr. Jason Cross. Dr. Jason Cross will be participating virtually. He's not been able to travel to Rwanda, but he's connected already, and he'll be able to participate. Welcome, Dr. Jason. A while ago, I saw him connected. I think we'll get him in a few. We also have on our panel today Mr. Dino Celeste. Mr. Dino Celeste is a co-founder and managing partner at Celestis Clientelis Africa. Mr. Dino, you're welcome. We have also on the panel today Mr. Sineka Samuel Siavana, representing Zipline in this session. You're welcome, Mr. Sineka. On our panel today, also we have a virtual representation by Mr. Ellen Greggio. He's a program advisor and monitoring and mapping at WaterAid, Mr. Greggio. He's also going to be connected virtually. Thank you. Thank you very much all for coming. We've been talking about improving the healthcare sector, and one of the threats to improving the public health means transforming the healthcare sector through technology. Is a pressing concern for the world, and the technology can help to design prevention and wellness models. Over the last decade, we have seen impressive progress in medicine. Today, we have access to artificial intelligence in form of robots. We've seen that here in Rwanda, we were able to use robots to detect the vital signs and reduce the risks of doctors having to be near patients and easily contaminate the COVID, which was very contagious. And those robots and doctors used to operate and implant made with 3D printing technology, programs that analyze large volumes of data, what we all call big data, to resolve health conditions in seconds, artificial intelligence, processes that give quicker and more accurate diagnosis, and mobile devices and applications that help patients with chronic diseases. This list is an addition to pieces of equipment that can help patients make speedy recovery while reducing the health system's costs. However, all this sounds like science fiction, something far removed from a reality in which the paper culture is still in play. I've been in the digital health space for the last 15 years, and amidst of all the technologies that you can deploy at a health facility without the proper governance, without the proper processes, without the proper culture or mindset to change the mindset of citizens to move and turn to digital health usage, the technologies will stay at health facilities, and citizens or healthcare professionals will stay using their papers alongside the technologies that you have deployed. With this, I'm going to welcome our first presenter, who is Mr. Muhammad Semakura. Mr. Muhammad Semakura is a health scientific innovator, innovation analyst at Rwanda Biomedical Center. He's a PhD student. He is a senior statistician and a data scientist with strong knowledge in designing prototype of health information systems, evidence-based strategic planning and organization. He is a researcher in statistics method, focusing on modeling infectious diseases, concentrating on spatial and spatial temporal models. Mr. Mohammed, welcome, and I would like you to enlighten us on how Rwanda is handling the integration of technologies in medical and public fields and public health field. Thank you.
Thank you very much, Edith. So, can you present my slides? So I think I'll be happy to share with you a number of slides so that we can have a discussion after looking on those slides.
We will ask our colleague to display the integration PowerPoint for Mr. Mohammed. Thank you.
Okay, thank you very much. The journey of integrating technology in medical and public health, it is the way to go for the future and for the sustainability of health sector, especially when you are saving lives. I'll take an example of Rwanda, especially basing on the COVID-19, just to show you how quickly we proved that technology can play a bigger role in terms of containing and controlling the spread of disease. Just a recall back, Rwanda started the prevention measures before having any case of COVID in the continent. By the time there were some cases in China only, Rwanda was already starting with preparation. And that time I remember we were doing screening at airport, especially tracking people from the countries that reported a case at the time. And in February 12, the first announcement, in February 12, we had to set up a scientific advisory committee so that can advise government and policymakers on what to do in case of this kind of situation. On 14th March, we had our first cases. But during that time, among the preparations that people were thinking about, the technology played a big role. Everyone was discussing on how to use technology to track. First of all, that disease that was coming, no one knows much about that disease. So the only way to prevent that one was to see how to use artificial intelligence so that you can avoid much as possible the contact between individuals and any suspect. Next. So one of the big things that the government made immediately was to set up a COVID-19 national coordination structure, which has several levels of leadership, but including the operational, where we find things like epidemiology operations with several cells. And this structure was not replacing the existing structure of health, but it shows that there was a need of bringing everyone on board in order to control this disease. And that's why the government immediately, they had to set up this coordination mechanism that includes experts, people from health sector, and non-healthcare private sector and so on, so that we can work together. But my focus, because it's on technology, this first structure that they put in place, they took something like data management as a small component under operation, epidemiological operation. But by the time people they started to work on operation, they found that actually that data management was not enough to cover the work that was needed. If you go to the next slide, you will see how they changed immediately to empower the data science component, because we have realized that without data science, it would be very difficult to control the spread of COVID. Next slide. And that's how the structure changed a little bit. And then we had to come up with data science, which had two components. There's IT solution, and there is also data management as data management. And data science became one of the big components. The reason was that the leadership was supporting, and everyone could see the requirement of having an IT solution and data science as a core. When you look on epidemiological operation, like what was needed to deal with this COVID, we found that there were 8 components, and those 8 components were very essential to deal with COVID. One, we had to set up investigation team. So when I'm saying to set up investigation team, you need to understand that team will need some tools, and those tools has to report information on the real time and so on. But by the time we didn't have all those tools in place. We had to have contact tracing system. So contact tracing system, there was no tool because we didn't have this type of disease at the time. And then we had to set up a system for that one. The way our laboratory system was, we needed to make some change so that it can work properly to deal with this COVID. The same, maybe you know that in Rwanda, the way we managed COVID, we had to set up some treatment centers that are separate to the normal hospitals to avoid the transmission of COVID within hospitals and also bringing other problems. So that's why we had to set up some separate treatment center for COVID to avoid those problems. After making all those changes, this is how it comes. We end up with having this national digital system for COVID. First of all, we came up with a USSD system that people can use so that you can know whether you are at risk of COVID, and then the AI system will advise you to go to test. That is the first column. Then the next one, Viero, we had also to come up with a system basing on WhatsApp, doing the same approach, so that everyone in the community, they will ask you some question in terms of symptoms and so on, and then they will advise you that you need to go to test, and this will indicate you where to go to test. So everyone could just look on that one. It was a kind of screening system. And we had to build a system specifically for that testing. The reason was that when you are testing of COVID, most of the time when we started, we were testing mainly the suspected cases. And then if someone is a suspected, how are you going to interact with that person? Of course, you have to put PPAs, and you know, not everyone will have all those PPA at the time and so on. Then to provide the results, it was also a problem. Is that person going to come to laboratory to pick the results? Is a paper or so on? So all those things were a little bit challenging, and we had to find the IT solution so that if someone is tested, he's going to stay in quarantine or he's going to stay at home, and he will get the result either on the phone or on email and so on. And then if those information has immediately to be reported to the other team of investigation and contact tracing so that it can trigger their activity immediately. So we needed a kind of real-time systems that can help us. And those information, they had also to be linked with a laboratory information system so that you have a full real time. And The second, we had to manage some of cases, but contact, they was also supposed to go tested and so on. So some contacts most of the time were at home. So we needed to come up with a system to manage contacts at home. And let alone, when the cases are increasing over time, we had to come up with some criteria of selecting people who are not really sick, who doesn't have a symptom, though they tested positive, they can be also managed at home. But we needed a clear system to help us to manage our patient at home without also transmitting, without creating another problem, transmitting the disease within a household or in the community. And that's one, we wouldn't achieve that without having the technology, because we had to make sure that we know where everyone who is positive lives. We had to do an assessment at their home. We had to calculate the risk of transmitting from others. And we had to do that without people going in their home and so on. So then we had to think how technologically we can do that. And it was somehow successful. But to do that, we had to change some of things. Next slide. So the main thing that we changed, you look on this laboratory system that we had before COVID. It was somehow semi-paper system. Because when they are going to correct a sample, they had to fill a form. And that form, they have to take the form with a sample to the laboratory. And then to the laboratory, they had to register that form. They had to put on the logbook and then send it to the processing system. And then after processing system, that is the time they have to enter those information into a laboratory information system. And then after entering information in the laboratory system, they had to continue sending the sample to the testing machine where they have that section of testing. They will get results, and they will get results on a paper sheet. They wrote it on paper sheet, and they have to send the results to be captured in laboratory information system. And then laboratory information system has to send the response to the patient and so on. So, and this structure was a little bit having, first of all, it has a lot of stages, but also during the implementation, you should get, there was a possibility of infection, having infection, because you have to go to the field, you have to test the suspect, they will be touching the papers that you are using, you are taking the same paper or you're interacting with them, you bring those samples to the laboratory system. So there was high risk of transmission within the laboratory system. So we had to assess all this, and we made a small change, just a small change, and everything became somehow perfect. Next, please. This is what we did. We decided, can you go back? We decided to remove stages from 9 to 3. We cut the stage. The first stage was, instead of going to capture the data with a form, we capture the data with a tablet. And then because we developed a system which was synchronized at national level, and this one we didn't develop a new system because we had already the systems in place, because we have those infrastructure and so on. It was just changing a little bit on flow and how the data will be flowing from sample collection to the laboratory. And now when we introduced capturing data from a tablet, it became quite very easy. At the time, after capturing, people at the laboratory, they can see that this sample was captured. Then the transportation will be only for specimen. Specimen with a code bar. And then when they bring to the laboratory, they can immediately see the code, and they can retrieve all the details of that particular individual. and you send the specimen to the testing, and then after testing, the information are linked with national, with laboratory systems and send information results, and the results will go direct to the patient through SMS or email. And then we avoided all the chaos things that we were expecting without changing much of things, but just understanding this flow and using technology, it's make a little bit a change. So, and this is what we did in the terms of the treatment center and the isolation. We didn't bring something new in the treatment center. It's just to introduce the new tool, the new way of capturing information and synchronize, and then develop some of new technology to pull information from national data center, from the central server to all the people who need to use it during that activity through API or other technology. So you pull information because all the data is centralized. If people from investigation team, they need data to go to investigate someone who tested positive, then you don't need to develop another system. You just pull data from the central testing system through API. You make an external tool to accommodate the requirement for the investigation team, for example, and then you'll be getting information that they need. And that one also helped. For instance, during that time, we needed to have some of dashboard to control the progress so that decision makers can take a decision very fast and so on. So what we had to do was to develop tools that can pull information from central server and then display those information that people they need to take a decision. The similar stuff that we did when we looked on the treatment centers, we found that we had the risk of our health providers to be infected. First of all, we had few health providers, and when we calculated in average, we just saw that at least one health provider in average will visit a room of a patient 4 times a day. First, you go there for taking the vital symptoms, then delivering some of needs and so on, medicine and so on, food and so on. And that one would be like 4 times a day. And we, despite being full protected, but there was some probability of getting infected. And then I say, well, what if we replace some of services with robot, like vital symptom? If you want to take vital symptom, the robot can do that. The same, or delivering in case needed. The same at airport, when we were thinking to reopening airport. So we could imagine how are we going to enforce the prevention measures and so on. And that's one, are we going to hire people always saying, hey, keep distance, wearing mask, temperature, and so on. So then we had some robot customizing so that the robot can go through and do that job, which became more efficient because you are using the human resource properly instead of having people just there for ensuring that people, they have to make sure that the measures are respected. So that's one. Another point was, you know very well that Rwanda is a landlocked country. At the beginning, we were afraid of transmission from other countries, but also we needed some goods because we are a landlocked country. Then we had to allow people to come in, but ensure that those people, they are not transmitting. So they had a precise place where to stop and so on, well controlled. And then our men in uniform, they had to follow those cars every time when they are entering. And we decided to see how can we come up with another approach instead of let people always following the drivers, the truck, and so on. We come up with a tracking system using GPS where we can track the car from one point to another point, and whenever someone stops in an area where he's not supposed to stop, we could say, hey, what are you doing there? You are not supposed to stop there. And because we will have people around, they will also immediately get information and they go to see what is going on. So those type of technology, they contributed to reduce the transmission of imported cases just with efficient system without having much resources and much of men in uniform following people to make them uncomfortable and so on. Apart that one, just giving some of example of the technology that we are using. At the beginning, when people are doing contact tracing, you need to make investigation. You have to discuss with people, so that they can tell you the people they have met, where they have gone, so that you can trace them. At some time, you find that people, they don't remember exactly who they met. And then you can, for instance, if I have been in this conference, I can't tell who I met. But there was another possibility. We developed some mathematical algorithms that can help us to identify someone who is near another using the telephone number or the antenna data and so on. You can make a gradient of some meters, and you can see those numbers in that gradient. And our contact tracing team, they can call them and try to test them and so on. And that one also helped. You can see you get one person, you get some positives and so on from there. Another thing that we did was that though in country we had some lockdown and so on, there are some of essential services that's needed to operate, like supermarket and so on, where people, they will get some needs. That's when they cannot go into lockdown. So they can also be a source of transmission. So what we were doing is just to map all those essential services and then use to do a permanent surveillance to those people, testing them often, so that we can try to detect any infection before there's much transmission. Apart that one, all those data systems, the way we structured our system was almost linked with the analytical tools. Because sometimes when you are making your health system, you only think in one angle, but you should think on comprehensive angle. You make a system provide services, but also you can use those information as analytical to help decision makers and take decision. So those are some of dashboards that we're using. Some they are public, like this one is public to that link of RBC, but others, the others, they are internal. Next slide, please. So some of tools are internal, like managing the vaccine, knowing where to put the vaccine site and so on, where just our people to take the right decision on the right time. We're using those tools. Those are some of the internal tools that we're using to know where appropriately we can put a vaccine site, because at the beginning, for vaccination, we had some criteria and so on. So we had to, based on some data, and know where to put a site or managing the vaccine and so on. Next, please. This is just one example. This is in Rusizi. That's in west part of Rwanda, on the Lake Kivu, where Rwanda is bordering with Bukavu. And those red dots that you are seeing are households that has a positive case in. And on the other side are our investigators. Because the investigators, they had to go to each of household to ensure, maybe to test the other members, teaching them, and so on. So we had those tools that would help us to do that work. So before going on the field, you know exactly where you're going, you get the briefing, and you can see, you have a map, you have all the tools that can help you to do your job. And then if you look also down, those are some of predictive models that we used to do. Like we need to monitor if the disease is under control or not. You have to calculate like the RT and so on. So the same tool we had, we monitor the death and so on. So we had those tools in place. So all those are based on technology. Apart those services that we are getting, we can get other benefit on integrating health system. Next, please. Those are manuscript, scientific papers published without going to collect new data. No, the data that we have into the system, people, they manage it to write some papers and publish it within a very short time, because the data that you are having, the system that you are having, are enabling the scientists, our scientists, to do some research very fast. So apart having a system which is functional, it can actually inspire even the world through the scientific sharing and so on. Apart that one, next, it's helped even to easier the access of services. This is app called RBCC19 app. And it's also fetching data from the same system. We don't need to develop another system. It's now available on Google Play, Google Store Play. It's called RBCC19, where you can see yourself checking. You can still get all the services of COVID that you are getting. The one in green, when you have your test within last 7 days, it should be green. When it's above 7 days, it should be red. That means there are some of promises you will not be allowed to enter. And I'm quite sure if you have been entering here, you didn't see what they are using, the security, but they are using this app. They are checking on that, and they will allow you. So if you are not tested, they will tell you to go to test somewhere. So that's how it works. Okay. So I think that was the end of my presentation. Maybe this one will stimulate some discussion, but adoptive and innovation technology can save lives in health sector if they can do it. It's not actually difficult or costly or impossible. It's something that people can do. Secondly, when you need to communicate the risk communication, especially during this pandemic, you need to come up with a strategic way of people to get information in a proper way, which is not the tradition. Another very important point is remember that the data-driven prevention are the only things that work. So Rwanda government and health sector, they are striving to digitalize the health so that we can save lives of our residents and other people. Thank you very much.
Thank you very much, Mr. Mohammed. Mr. Ellen, I think Madam Ellen has just joined now, and we welcome. Good
afternoon, everyone.
Ellen.
Thank you.
Greggio. She is an advisor for monitoring and mapping Water Aid UK. Welcome, Mrs. Ellen. You'll be following Mr. Jason after this session. Thank you, Mr. Mohammed, again. Integrating our healthcare systems is a very paramount point that Rwanda is focusing on currently. We are building one of our health information exchange that will be the heart of the digital healthcare in Rwanda. And one of the key components that we are focusing on, we are making sure that it has around 6 registries. One is the Client Registry. If you've been vaccinated here in Rwanda, you've seen that when you're asked your number, immediately by the time they finish to enter your number in our vaccination system, all your details are pulled from our NID system. We have all your credentials because there's an integration with our healthcare system between NID and the health information exchange. And we are building the Client Registry to ensure that every patient that goes to the healthcare system or to the hospital, either they are being treated through our electronic medical records or the open clinic or any other electronic medical records, will be able to identify uniquely each patient in Rwanda. And we are trying to build a unique number that currently we are calling a national identification number that we have started even giving to the newborns. And we've been identifying the above 16 with a national ID, but we'll be sure that every citizen in Rwanda is identified by a unique identifier, which is a national identification number. And with Health Information Exchange, we're also integrating all the, we are developing what we call the shared health record to ensure that if I've been treated at a health center A and tomorrow or after a month I go to a health center B or a hospital, I've been referred to above level to the hospital, the physician or the doctor will be able to see my patient history. They'll be able to see that I'm allergic to this and this. They'll be able to know what the doctor has done for me in the past to ensure that they don't spend much time asking me the same questions that the previous doctor has asked me. And we've already finished developing our national product catalog that has a list of all our essential medicines with international codification of ATC standards put out by the World Health Organization. It is recognized internationally, but also another registry that we're working on is a terminology services that will codify all the diseases, all the medical procedures, so that if in hospital A they call a disease A has this code, it has to be similar in all hospitals. It has to be identified similarly in all health facilities. So integration is very key to ensuring that we are bridging the gap between the patient and the doctor to ensure that we are improving the patient journey in the digital healthcare space. With that, I'll allow Mr. Jason, if he is connected, to share his remarks. Thank you. We welcome you, Mr. Jason. Jason Cross.
Thank you very much. Can you hear me okay?
We can hear you, Mr. Jason.
Great. I'm going to share my screen very quickly, a presentation. One second. And is everyone able to see that?
And as Jason connects, I think he'll be able to introduce himself. He is a co-founder and chief strategy officer at Remedy, and I'll allow him to introduce himself more. Thank you, Mr. Jason.
Well, thank you very much for the opportunity to speak with everyone. My background is global health innovation, law, policy, and business strategy. I used to be a professor at Duke University and lead a think tank on health innovation there. And a lot of my work has been in emerging markets, working with ministries of health, pharma, and medical device companies on innovative partnership models to expand access to affordable medicines and devices. And that's ultimately what led to my co-founding Remedy, as a technology company to provide the technology and the data infrastructure to enable innovative business models that will expand access to medicines and devices. One of the big barriers that is very familiar to all of you is when you try and get multiple parties to work together in some project that ultimately is about outcomes, there's a lot of mistrust in each other's performance of what each organization is supposed to do, and a lot of mistrust about information regarding what was done, information about baseline health situation, et cetera. So I went and co-founded this company with my co-founder and CEO, David Stefanich. It's an honor to speak with you all, especially given what I just heard, the prior presentation and the moderator's comments. It's going to, as I try and talk about the paradigm shift from digital to connected health, I think it's very apparent to me that Rwanda is already there and in many ways is far ahead of many localities around the world. I would say certainly far ahead on many fronts than a lot of places here in the United States. So let me get started. Again, broadly, our vision at Remedy is to use technology to expand patient access to high quality healthcare. And as a result, we work to make healthcare more efficient, effective, and available to all. So the COVID-19 pandemic accelerated digitization agendas across healthcare in many countries to enable remote care, enhanced tracking of cases and scenarios, improved and faster reporting of information. However, difficulty coordinating between these complementary components of a patient care cycle, often digitizing in their own little silos, continued and continue across the world to hamper COVID-19 and other kinds of healthcare response. Data privacy, security, data integrity, compliance concerns all remain bottlenecks to digitally coordinating across a care continuum, especially if you have different organizations. One of Rwanda's advantages is how central the Ministry of Health as an institution is present across the care continuum. And that makes it a little easier to get everyone aligned in terms of standards. In a lot of the world, it's not that simple. This presentation, therefore, describes how a blockchain-based connected health platform is working to clear that bottleneck and ultimately improve multi-party coordination in testing, treating, and monitoring COVID and many other diseases. And these examples hopefully will demonstrate how greater trust in processes and data across decentralized organizations will point the way towards massively scalable reinvention of organizational and business models of healthcare delivery. Here on this slide, I just illustrate that the path to agile health systems really runs from digital health through what I'm going to talk about as connected health. When we talk about digital health, we're often talking about use case specific software applications or data applications that are either assisting patients or assisting clinicians or monitoring activity, monitoring patient or healthcare activity in the form of health records, health surveys that patients may fill out with certain conditions where that extra monitoring is important, integration with all sorts of sensor data, et cetera. And often that info stays in the silo of the organization and the people around that use case that care about it. And that information can be very valuable across the healthcare continuum, and often it's not harnessed for other purposes. And it's been exciting to see in the last presentation the real data architecture progress that Rwanda is making in enabling data captured for one purpose to create value in all these other places. At Remedy, we designed a platform with various use case solutions that is geared towards simplifying this kind of data capture and data sharing across use cases. Our connected health platform offers 5 comprehensive solutions to improve the quality and data monitoring of various kinds of testing, treatment, monitoring of patients in various activities, health research, and also manufacturing and manufactured product use out in the real world. Our management layer on the platform is common to all the solutions, enabling leadership of organizations that use it to have real-time oversight. The platform's agnostic to various tests, treatments, electronic health record systems, et cetera, very flexible and interoperable, so that allows healthcare organizations to have total flexibility, no lock-in in how they're digitally integrating treatment, diagnostic testing, and so forth to rapidly scale across use cases. And it also automates a lot of regulatory compliance in terms of processes, in terms of data integrity compliance, data reporting when certain government agencies or certain laws may require certain kinds of information to be reported to certain organizations. And the architecture layer of the platform is cloud-based. It supports mobile access through browser-based applications, and it's designed to be utilized in all kinds of scenarios, especially low resource settings. So this platform ultimately prioritizes a simple patient experience while simultaneously increasing the quality and useful life of data. We capture patient health information as FDA admissible real world evidence. So it has the data integrity that a monitor clinical trial would have, which can be used to accelerate product approvals. It enables remote patient monitoring. It leverages de-identified data for secondary research. The streamlined workflows, I'm going to give you an example in the COVID domain, improve clinical productivity, and they often reduce errors, thus increasing patient engagement and satisfaction while providing the organizations that use it less administrative burdens. The solutions are built on the common data architecture that overlays over legacy systems, which helps in normalizing data and processes across organizations and enterprises. So not just very interoperable, but even when you can't have a digital API integration, it's designed to easily overlay and complement existing IT infrastructure. And our patented blockchain-based data privacy and security unlocks value from strategic partnerships by eliminating all kinds of data sharing risk. So in 2018, my co-founder David and I developed the solutions in the Remedy platform in a global health context while working with the World Health Organization, the government of Mongolia, Cepheid, and other companies to address the rampant hepatitis C epidemic in Mongolia. And it was at that moment that we saw the immense value of how a digital workflow platform could systematically be used to test, treat, and monitor an entire population for an infectious disease. So when COVID-19 hit, this was just another disease for us to address, though one where time worldwide was of the essence. So I'm going to give you a brief example of Clemson University is a large public university in the United States with over 25,000 students, faculty, and staff. A lot of the students living on the campus of the university. They reached out early in the COVID pandemic, and within 48 hours, we were able to deploy the platform and scale the testing program there to 25,000 students, staff, faculty, and community members once a week. Now, in this activity, there's several points that I'm going to show a video in a minute that will illustrate, but one is that the proactive testing strategy rapidly reduced cases by 95%, while the rest of the United States was hitting COVID peaks. The testing centers, because of the digital workflow and the efficiencies they provide, they operate with a staff of 15 personnel across multiple locations who will test between 5,000 and 8,000 patients a day. And our staffing partners tell us that they would normally need like 75 staff to do that. So the labor savings just for Clemson University ended up being significant, several $1 million actually over the school year. And ultimately, the kind of efficiencies I'll demonstrate help lower labor costs and enable higher volume across a variety of our partners that are working to quickly address COVID via testing or vaccination activity. So now to bring the testing solution to life, I'll show a brief video. Again, we're very proud to have had the Clemson case published in the Lancet. And as I describe what is happening, note the simplicity of the experience for both patients and health workers, staff, and PPE savings that would result from the efficiencies that the digital protocol controls ultimately that assure that everyone is following the right steps in the right order. So here, this is an accelerated video of students. Once they've registered, they have QR codes that are tied to their identity, allows them to go through testing or vaccination activities purely anonymously. They're asked a verification code there. In this case, this is a saliva PCR test sample collection. So it's as simple as they get their code scanned, they're asked a verification question. What's the third letter in the name of the street that you live on? What's the fourth letter of your last name? Something that maintains anonymity, but allows that secondary authentication of the identity. They walk on, they deposit their sample, and off they go. That sample is scanned at every point of change of custody all the way through to the lab. Real-time results are sent back to the student, but also to, in this case, the university administration. In the case of employers that we work with, their employee safety department, with governments, whatever relevant government officials, so that they can act in real time with patient care, quarantining activity, contact tracing response, and so forth. And that also, that process, we also automate regulatory reporting to state agencies in the United States, the federal Centers for Disease Control, and so forth. So this real-time digital integration of all these activities is of itself valuable, but the simplicity of the process allows for not just savings in terms of labor costs, but it allows for less training requirements for people to participate in those testing activities. So it makes it easier to have more remote testing, or in the case of vaccinations, more remote vaccine administration with so long as the minimum standard of health worker training is met, because they have that assistance of the digital workflow. Additionally, the dashboards and analytics in this case are used in real time by the university for to prioritize certain subgroups. So if there's a threshold of cases in a particular dormitory, then everyone in that dormitory gets notified that they need to show up within the next 5 hours to get tested. So you can catch hotspots quick and fast. And then a lot of that data is used for predictive analytics that allow for the health system of the campus to plan ahead in terms of supplies, various kinds of protective equipment, and supplemental staffing. So they'll know ahead of time, sometimes a couple weeks ahead of time, when they're going to have an uptick, and be able to get temporary healthcare staffing to be able to support those patients when they get sick. Furthermore, external testing by external labs is easily integratable when there's need for that kind of surplus capacity. A few additional benefits that parallel what was presented in the Rwandan health system case earlier. So once you have this kind of data and workflow infrastructure in place, that data can be used for lots of other cases because it has the highest degree of security and data integrity from a sort of clinical trial grade standard. So Clemson University, which does not usually participate in clinical trials, was able to be a clinical trial site for the Moderna vaccine because they had this infrastructure already in place. So the additional capture of data elements necessary for that trial was much easier for a university in the United States that doesn't have a medical school, and so therefore they usually don't participate in trials, to do so very simply. And also the same infrastructure is ultimately used for vaccine administration, and has been a platform for third party, primarily health engineering teams at the university to develop additional apps to better support patient care that run on that same data architecture. So again, the connected health story is enable process quality and data of highest quality to be of value to other kinds of health solutions, other kinds of processes, and other kinds of use of that data. And ultimately, the point of this talk is to show that digital health tools become valuable when connected beyond the immediate impact of their assistive or monitoring functions. They connect patients, providers, administrators, regulators, and product suppliers in networks where greater coordination and trust enable qualitatively new ways to improve healthcare quality and access. So having seen the testing workflow, you can now understand how the digital workflow helps pharmacies, laboratories, and health systems address the complexities of COVID vaccinations. So here you have an overview of protocol controls, patient engagement, treatment verification and tracking, and reporting automation to patients, providers, government agencies on the initial first dose vaccine, follow-on monitoring for second doses, notifications for boosters, as well as pharmacovigilance. And our vaccination partners have highlighted the importance of syncing supply chain tracking and vaccine registration with the administrative digital solutions. So, proactive supply inventory and scheduling management is then possible by leveraging a lot of that that vaccine administration solution data and processes, and can help in terms of proactive inventory management and avoid a lot of shortages and stockouts that are both difficult in the moment for health workers and patients, but all of which add uncertainty and damage public trust in vaccination campaigns generally. Now, how does blockchain play a part in the value that we create here? First, our approach to blockchain is based on leveraging the benefits of it for change control, create an audit trail, create multi-party trust in data, and enable cryptographic verification of data and events, and also zero knowledge proofs, or what that refers to in the world of blockchain technologies, cryptographic verification without needing to disclose the underlying data being verified, for reporting to AI analytics models, for data mining, etc. All the while, we use it in a way that's maximally flexible, fast, scalable, and maintains patient and customer control of their information, including the ability to delete it. So for a high-level review here, meet Sarah. She can access her data via any mobile device as it is encrypted on distributed networks in the cloud. In short, the blockchain gives her control of ongoing use of her data and makes all uses of that data on the platform consistent with her permissions. Her personal information is encrypted on one private blockchain network, and her health information is encrypted on another private blockchain network. And what Remedy's blockchain platform does is it requires a cryptographic key to each private network and a third key that's tied to a public blockchain protocol for any use of the data. This provides extremely high cybersecurity, the highest patient data privacy compliance, and gives patients, customers, and governments the highest level of control of the use of the data. And one result of this blockchain platform is our ability to automate a lot of process standards and digital standards compliance across lots of use cases. And the application layer solutions may focus on different points of a patient care continuum, but the underlying technology of the workflows is the same, all running on a platform that's automating clinical privacy and other standards compliance. This makes digital tracking and reporting across various points of the patient care continuum in simple, seamless ways, easy, interoperable, and massively scalable. Now, we're very honored to be partners with MedAditus, whose CEO, Dr. Darren Thacker, has been presenting throughout the conference. And I will join him tomorrow morning in speaking a little bit about how this kind of data technology is being applied to enhance the quality and accessibility of medicines alongside the MedAditus operations. In summary, I just want to reiterate that patient care focused on digital health tools are thus actually also providing the means of innovating healthcare logistics, administration, finance, R&D, and ultimately policy, with feedback loops in both directions. So in this way, digital health is accelerating more systematic health system-wide transitions, better conceptualized as connected health. The promise of digitizations has always been nimbler, more targeted precision health for populations and individuals. And experience is showing the path to precision health is via connected health infrastructure required to truly empower clinicians, researchers, and patients. We at Remedy are honored to be laying that infrastructure and inspired in seeing others, such as the Rwandan Ministry of Health, play such a leadership role in laying out those rails for connectivity as well. On behalf of our team at Remedy, thank you very much for your time and look forward to answering any questions and speaking further with any of you about connected health and how we can work together. So thank you.
Thank you. Thank you very much, Mr. Jason. You can hear the audience appreciates what you've shared with us. Indeed, connected health is the way to go. Our wish is that we could bring medicine closer to the patient more than we're doing it right now. With that, allow me to welcome our next presenter, Mr. Dino Celeste, who is a co-founder and managing partner at Client Registry Africa. Mr. Dino, would you highlight the growing importance of digital health and mobile health in low and middle-income countries, and also how can digital solutions and mobile technologies help to boost access to healthcare in Africa and enable countries to achieve the health targets of UN Sustainable Development Goals by 2030? Thank you, Mr. Dino.
Good afternoon, everybody. Thank you, Chair. I think this mic is working. I don't know if my presentation is on the screen. While I'm waiting for my presentation, I will start by saying, first of all, thank you to BS investment team to put together this conference besides the challenges of COVID-19 dispensation. And thank you also for the technical and production team to have spent their lunchtime to fix a big screen. Now we can have the presentation on the big screen. I think for the crowd and the audience, I think it's much better. You can go to the next slide, please. Yes, next, please. Yes, I'm going to go very quickly on this slide because my previous speakers has explained to you guys that indeed the COVID-19 pandemic has put a spotlight on digital health, and just for us, mankind, in our life, there will be a life before COVID-19 and a life after COVID-19. So the same applies to digital health. I think that digital health has been boosted by the COVID-19 crisis, forcing countries to step up and to adopt digitalization of the healthcare ecosystem. It's a real leapfrog on their digital journeys, and I think the Rwanda and LBC is a very great example in Africa of such a leapfrog and such adoption. Other example also in Africa, you have Ethiopia, who has created a Digital Health Innovation and Learning Center. In South Africa, where we are headquartered, the government has put in place what they call EVDS, Electronic Vaccination Data Systems, through which every resident in South Africa need to register to get their free vaccination. And so, yes, COVID-19 has just really boosted the adoption of digital health solutions across the board. Next slide. I'm going to go very quickly on this one, just to say that when we say digital solutions, we should say digital and mobile technologies, because actually mobile technologies and cell phone actually is bringing healthcare to the patient, to the communities. And in the day and age where everybody is speaking about patient centricity, actually digital technologies and mobile technologies allow and enable this patient centricity. Let's go to the next slide, please. Yes, there is a need for digital health in this context of COVID and beyond. What is important to say that this solution can support screening. First of all, can support advocacy on disease, and especially in Africa, it can support to fight against stigma about disease. We have in Africa many stigmas on disease, from HIV/AIDS to cancers, and to even COVID and vaccination. So digital solution help to fight against those stigma through advocacy is one. Number two, it helps in terms of screening. And number three is treatment, testing and treatment. Next slide, please. These are different multi-channel solutions that are used in digital health technologies, from cell phone to web-based application, even using your basic old phones through the use of USSD messaging. Next slide, please. We'll give you some example. Just after this very two great presentation, I wanted to give more example of digital intervention in the continuum of care and how it can improve access to healthcare. So as I said, from awareness to prevention to screening to diagnosis, through education, training, referral, distribution, logistics, which is a very important part in particular in the fight against COVID, and vaccine distribution, pricing, support of patient, and so on. So we have really a full hand of different aspect of healthcare can be supported through digital intervention. Another example is how about patient support program that can be used through digitalizations. What is very important in Africa, this morning we spoke about universal health coverage, is affordability. So digitalization can help patient to keep on adhering the treatment and through different type of process to keep taking the treatment, in particular for NCDs, non-communicable disease, and lifestyle diseases. Next slide. Yes, I'm going to give you some example of application that we have launched recently in Africa. The first one is DigiTB, is a digital solution to help communities and health authorities to tackle and reach and to track, reach and stop TB. It has been deployed in South Africa and is currently in a test in a province called Eastern Cape in South Africa. There is okay, it's only on the screen here. Okay, there's something on my screen here. The other application that we have launched in the start of the COVID pandemic is an app called Coftor, which monitor is a monitoring tool and case in the identification and lab test and contact tracing for COVID in South Africa. And we're planning to deploy this app in other African countries. We have another example of a community-based ICT for maternal and healthcare in Africa. I think this morning there was a session about maternal care. So another example, the app called Fakamisa was launched in South Africa and Kenya and also other countries in East Africa. Is an app that we put in the hand of healthcare workers and navigators. It's a mobile app for community awareness, what we call in South Africa townships, it's in communities and awareness screening and training that health workers can do through this mobile app for cancer screening and treatment, both female cancer, mainly breast cancer, as well as male cancer, mainly prostate cancer. And Pharma Consult is another example of digital solution. This one is a consulting pharmacist digital platform to enable community pharmacies to put in place a structured disease management program with patient. Next slide, please. Very quickly, this example, the one I mentioned, the DigiTB, is a responsive web-based TB application that has a video observed treatment platform, and this can be used also for COVID, and we're planning to use it for COVID also. Next slide. Just here, to give you an idea of our Helmes Africa application. It's an open source, multimodal and multilingual mHealth platform addressing community-based maternal and newborn healthcare delivery. And it has been deployed in Southern Africa and East Africa, Ethiopia, Kenya, Malawi, and South Africa. Next slide, please. This solution is a community workers-led program. I mentioned to educate, screen, and treat cancer patients, both female cancer and male cancers in Sub-Saharan Africa. The app has been deployed in South Africa and in Kenya. Next one, please. This app can be used for other diseases other than cancer. For instance, it can be used for any non-communicable and communicable diseases. We give you here on this slide how the health workers can deal with disease awareness and screening and management of patients across the healthcare ecosystem. And this app empowers navigators and healthcare workers in their activities, but also for the sponsors of such program, such access to medicine program. It allows them to track the activities and monitor the activities of NGOs in the field and understand the reach of the program and be able to have a lot of analytics on these activities. Next one. This one is another pharmacist-led program I mentioned. It's a web-based platform to monitor and to help pharmacists, community pharmacists, have this management program in the community. For instance, in the case of COVID, I don't know for other countries, but in South Africa, for instance, pharmacists can vaccinate and can test a COVID patient. So this type of solution empower the pharmacist to play also an important role in the fight against the pandemic. Next slide. Yes, just this slide explains to you how the app works. For any non-communicable diseases or communicable diseases, this app enables the pharmacist to have a video consultation, and also organize appointment with referrals with doctors and follow up the consultation with the patient. Next slide. It's an example, for instance, of this pharmacist-led program whereby, as I said before, in Africa often patients drop their treatment because of affordability, because many of them pay their treatment out of pocket. So this program is a loyalty program which enable through a free box after, if you say that your treatment after the third month gives you the fourth box for free, and this program help pharmacists to maintain a patient on their treatment through a free box across the continuum of care. Next slide. So, now I'm going to give some example of digital solution for COVID-19. I mentioned earlier before, there is COVTOR with a monitoring tool for COVID testing and contact tracing and testing and tracking. Next slide. And yes, what is important here now in the COVID fight is vaccination. I said that South Africa, the government had put in place an electronic platform, but in many other African countries, there is no centralized electronic platform to monitor vaccination for COVID. And above all, so we're proposing to develop and deploy such platform in African low and middle income countries. What is very important, such platform will also, not only for patient and HCPs, healthcare professionals, also help, I would say, bridging the gap of data storage. For instance, when you vaccinate with COVID, you need to have the data of the vaccination being centralized somewhere. Most of the time is lost. And specifically for vaccine, we require a second jab. You need to be able to follow up. So this solution will, through SMS reminders, will help patient to come back for the second dose to the vaccination centers, and to help the government to monitor vaccination and to know at any point in time how many people have been vaccinated in the health district, and what is the status of the vaccination activities and campaign. And above all, this solution will help with what we call AEFI, adverse event following immunization, or if you want pharmacovigilance. On this application, both patient and also healthcare workers at vaccine center will be able to report adverse event post-vaccination on the system. So, and the system also will be able to track and exclude and manage potential counterfeiting, vaccine counterfeiting, or fake vaccine in the system if it's entered into supply chain system of the country. Next slide. Yes, just give you just to summarize this solution, we're going to have electronic data capture at the point of care or the COVID Action Center, the CVC, and then the other module will be about the follow-up and notification for the second dose of the vaccine to the patient. And then the third module will be about generating and send electronically a vaccination pass or vaccine card to the patient. Therefore, they can access to different facilities with vaccination pass. So, just to summarize, digital solutions in the time of COVID can really help enforcing healthcare interventions, and we believe that today, as we speak, the most accurate issue is to maximize vaccination campaigns in Africa, and we believe that such a digital platform will be very useful to help government and communities moving forward with the vaccination of the population. Next slide. So as a conclusion, I will say that we have to prepare for the worst and plan for the best, as it was said previously. Yes, we have COVID-19 today. It might stay with us, and we can have even another virus. So we have to plan for the worst and prepare for the worst and plan for the best. And I will say, let's act together to fight COVID-19 and to build through digital technology the foundation of a new healthcare system, integrating digitalization across the continuum of care. Thank you. Next slide. Okay, thank you very much.
Thank you very much, Mr. Dino. Yes, we cannot deny that digital health or mobile health is very essential. In Rwanda, just to cite two examples where we've managed to use mHealth is with the community health workers. You know, countrywide we have around 60,000 community health workers, and those community health workers, their work is to track pregnant women and children under 5, and to ensure that they follow them up in the community and treat them, give them all the first aid, and when they have an emergency, there are alerts. We have what we call red alerts, and those red alerts goes to the nearest health facility, goes to the nearest ambulance for a quick emergency. If, let's say, there is an expecting mother who's bleeding, there is a need for emergency for that pregnant mother, then an ambulance is alerted for rescue, for immediate rescue. And this has really helped us to reduce the maternal mortality rate in Rwanda. And the other point is that we're also implementing what we call track and trace, tracking our drugs to the last mile of dispensing. And our patients or our citizens or our clients will be able to barcode scan the drugs that they have been given and be sure that on this barcode, the barcode that is on the drug, they're able to see if the drug is recognized in country. Was it registered by Rwanda Food and Drug Authority, our FDA here? Was it, am I able to even track it when it comes to the point of entry, either the airport or the customs? Am I able to track and know where, who's the manufacturer, which company this is being manufactured in? Those are key mobile health application benefits that are being used in Rwanda to improve digital health transformation. Without taking too much time, I'm introducing our second last presenter, who is Mr. Sineka Samuel Siabana, working with Zipline. Mr. Sineka, how has Zipline enabled remote patients to access healthcare services in low and middle income countries with limited infrastructure? And how have you brought care closer to the patients? What are your current life-saving statistics in countries you operate in? Mr. Sineka.
All right, thank you for the questions. If they could put on my slides, bringing care closer to the patient.
As he puts the slides, you know that globally, most women or patients lose their lives because they have no access to blood. Let me allow Mr. Sineka that now his presentation has gone on. Thank you.
All right, thank you. So I just want to put some perspective into place before I actually start with my presentation. So it's been a fact about universal access to essential medicines is a critical thing that a lot of countries are actually lacking. Equity to access of these medicines has brought a toll on people that are mostly in the ex-urban areas, financially, health-wise, deteriorating their health, and then impacting on agricultural production and all that. A case in perspective could be Rwanda, where we see that all those in the ex-urban areas are basically farmers, which means that if a farmer is sick today and goes to the hospital and doesn't get the drug, there are two things that could happen. Either the person is referred to an urban facility for healthcare, and we look at the cost implication, the transportation implication, the exposure, and then the probability of actually getting secondary infections while traveling is into perspective. There's loss of productivity because the farmer is not able to attend to their farms again. These people have to send additional hand, maybe a relative, cost of accommodation in the urban area, the cost of living in the urban areas for these people is so high. So the strategy of Zipline is bringing care closer to these patients instead of these patients going the other way around. So we have 3 models of operation. So Zipline, basically, when you go to Zipline, we have our warehouse, and this warehouse is where we have our inventory that has the standard of GDP compliant warehouses. So in Rwanda, we have 2 of these distribution centers, one in Muhanga, the other in Kayonza. And all these warehouses follow strict best class in SOPs, where we do first expiry, first out, to make sure that we optimize the medicines and avoid expiries and wastage. If you go on the demand delivery aspect, we have all the medicines in the warehouse are 100% available to all the facilities 24/7. So we do our operations 24/7, understanding the fact that people can be sick at any given time, and therefore we need to be there for them at all the time. This graph is showing us the kind of deliveries we have done ever since we started Zipline in 2016 till this very 2021, just in October. So if you look at the graph, you will see how exponential the number of deliveries has gone, and this attributes to the fact that the demand for area logistics is very high. The demand for this service is so high, and then the client base is also broadening. We are partnering with a lot of entities. We are partnering with RBC, we are partnering with the ministry, we are partnering with RMS, BTD. Day in, day out, we are broadening the scope of partnership. We are moving into private businesses and thereby broadening the scope of the clients that actually use the service. Yes, next, please. So a case in perspective is the continuing chemotherapy in the midst of the pandemic, where chemotherapy for cancer patients were basically given at the Butaro Clinic. But this meant that in the lockdown, these patients who had this comorbidity had to travel, thereby exposing themselves to the risk of contracting COVID-19, which is not good for their existing comorbidity. What it meant was that we needed to bring care closer to these patients. So instead of these patients commuting 2 hours to 8 hours round time travel, it just meant that Zipline, we could do the deliveries from our centralized warehouses to these patients, to the districts where these patients are, so that they could receive the treatment from their district hospitals rather than traveling to one hospital in the capital city. So if you look down there, it's actually Dr. Joel, whom were on the panel today, and then the testament that he also gave with respect to how Zipline intervened in the case of the people that had to battle with access to chemotherapy. So the supply chain solutions that we also bring is with regards to PIH. Sometimes what we mostly look at is speed. If you look at the makeup of our drones, they actually move at a speed of 120 kilometers per hour in air, and then they can fly in 80-kilometer radius. So we understand that speed is of the essence. Apart from accessibility and equity, speed is also of the essence. So when we were reached out to by PIH, we made sure the implementation was done on the 3rd day so that these people could get access to their medicines. And subsequently, these are the kind of experiences we actually want to have with hastening projects to realization and maturity for the better benefit of all those that are supposed to receive them. So how does the delivery of the cancer medicines work? So initially, it was just at Butaro Hospital. Every patient had to go there. But with Zipline coming into play, PIH has the client of all those that their medicines has to go to. Now, PIH doesn't have to travel to all these people to deliver their medicines. They had only 2 centers to travel to. That is Zipline in Kayonza and Zipline in Mohanga. From these 2 points, we could service all the patients of PIH that were in 19 districts, and these patients adequately had access to their chemotherapy in their respective district hospitals. So one was instant resource mobilization, where we had all the resources, and then we were able to get the products from PIH and then distribute to these patients. The other one was also real-time data visibility and tracking, where we were able to provide an interface where PIH could see that we have delivered chemotherapy, this quantity, to this patient. So they had that real-time data visibility and tracking to know where each tablet of chemotherapy had gone to, so that they were also comfortable that the medicines were adequately being sent to these facilities. And then we had a continuous and resilient operation where Zipline actually reduced the risk and increased the operationalization continuity of these autonomous delivery to all these locations that these patients were. So bringing care closer to these patients, now these patients didn't have to travel long distances of turnaround time of 8 hours. It was just done in an hour now. They didn't have to spend so much money to the urban area to receive medicines. They just had to travel to their local comfortable district hospital, and then they received the same amount of care they would have gotten if they had traveled this 8-hour travel time. And this also had a very huge economic implication for these patients as well. So what does the future of logistics innovation look like? So with Zipline, there is another phase of innovation that we are bringing, which we term it as the home delivery phase. And this is, apart from flying into the ex-urban areas, we are trying to do home delivery where we are trying to go into partnerships with private pharmaceutical industries, private manufacturers of medicines, any other entity that is interested for delivery services to leverage the area logistics to be used. So one of the currently we are in the pharma business where we already transport medicines. We are looking at how to strengthen Zipline business using e-commerce, and then also how to get partners who want their products also being delivered either at the comfort of people's homes or even at the extremities of the countries where we can partner with to do this project. So this is practically what the future for Zipline holds for us. And this is what I want to share with all of us today. Thank you.
Thank you, Mr. Samuel. Mr. Samuel Sineka. We really appreciate contribution of Zipline in Rwanda. In the midst of COVID-19, we appreciated how distribution of non-communicable diseases drugs was done, and we managed to save more lives because people are not left out. And also, we appreciate your contribution in distributing blood products to those in need. And I, being a lady seated here, I know that us women need blood products more than anyone else, and your contribution has been really paramount. Quickly going to our last presenter, Madam Ellen Greggio, who's a program advisor and monitoring and mapping at WaterAid UK. Please, we would like you to brief the audience on closing the gap using ICT to accelerate data collection and use to improve quality of care of healthcare facilities. Also, we would like you to shed some light on how we can leverage access and use of ICT to support evidence generation around environmental determinants determinants in health, focusing on generating increased data availability and analysis of water, sanitation, hygiene, environmental cleanliness, and solid waste data in healthcare facilities. Waiting to hear from you, Madam Ellen Greggio, if you're online.
Great. Good evening. Can you hear me okay?
Yes, we can hear you. Thank you.
Great. I'm trying to put the video on, but I can see that it's taking a bit of time. So my computer is not very happy. So I have Ronald Okwa from WaterAid Uganda team, who will be presenting a specific case study as well. So as introduced, we will be talking about how we're using ICT to accelerate the availability of data about WASH as key component for healthcare facilities. And hopefully. So WaterAid, you might have heard some previous presentation from some of my colleagues, but just quickly, is an international organization that works on, specialized in WASH, both in communities and institutions. And our focus approach to work is on both service deliveries, but also system strengthening and ensuring that there are the right functions in place to ensure that the systems continue to last. And one of the key approaches that we work with is also on integration. So integrating WASH within existing health and education programs, for example, to ensure that we can have a wider and larger impact, but also that some of the services are being sustained as they're part of health and education systems. So why are we talking about WASH in health? As we said, integrating WASH in health is fundamental for improving the quality of care and for strengthening the health system and communities' environmental and behavioral factors. And why is this an issue? This is an issue because across the world, we still have 1/3 of healthcare facilities who have no hand washing facility, 1 out of 4 healthcare facilities which have no access to safe water supply, and 10% of healthcare facilities that do not have sanitation services. And this is across the world. So we really we want to really focus the presentation on to represent our work that we do in terms of supporting WASH in healthcare facilities around the evidence generation so that these gaps are identified and improvements can be planned to address these service gaps and therefore this gap in capacity to ensure quality care. And also working in more widely in the public health sector by combining WASH data with health data to identify some of the hotspots of health issues that can be also addressed through WASH and therefore prioritize where WASH intervention needs to be targeted. So one of the real big focus of this discussion is very much about the data gaps. We heard some of it previously in the previous presentation. And what's the role of ICT in all of this? So obviously ICT has a major role to play. We've been hearing a lot already in the previous presentations for what it can support in the health system. If we look at the WASH in health, it can really support Ministry of Health, Ministry of Water to inform a number about what healthcare facilities, water and sanitation and hygiene and environmental cleanliness and solid waste access and services are, but also to accelerate generation of data about the services so that it can inform planning and budgeting, but also provide real-time information, as we heard previously as well from other presentations about supply chains. In this case, it's more about operation, maintenance and management of water supply and sanitation services. It also can support very much with accountability processes for increased data transparencies and data sharing, and facilitate also user reporting mechanisms. So there's a number of roles ICT can play, and these images here are just actually examples from WaterAid's work, where we're looking at sensors integration into very remote locations where only hand pumps are present by having sensors that can track functionality, water quality, real-time water quality testing that's been done and reported from mobile phone so that data can be available for the decision makers, and online visualizations. And we'll go into more details of that in a minute. So when we're talking about WASH and the 5 components that we mentioned before, water, sanitation, hygiene, environmental cleanliness, and solid waste, there are a number of monitoring frameworks that already exist for WASH in healthcare facilities. We have the joint monitoring program, WHO and UNICEF, which collate information from national governments, National Statistic Office, related to the 5 components in healthcare facilities and provide a global overview of progress. They also provide recommended survey questions that can be used in the sector. There's another tool developed by WHO, which is called WASHFit, and this also supports identifying areas that require improvement in healthcare facilities and to help with detailed planning and budgeting. And this is also built on ICT. The WHO and UNICEF, there's an online platform that does automatic visualization, so it can be used for analysis. There are national service assessments that have already been made. And then obviously we've been hearing DHIS2, health management system in some countries being used. So the reason why I'm saying this is because we, as WaterAid and as a sector that works in WASH in healthcare facilities, we're not trying to introduce new processes. We really want to try and streamline some of the existing frameworks and indicators that are already present in the sector, but make sure that these are available. And why is this? There are some major data gaps in the sector. If we look at this graph here that is presented, these are the 5 service levels for water, with the blue, green is sanitation, then we have hygiene, waste management, and environmental cleaning. So we see that there are major data gaps for the least developed countries on information about hygiene and cleaning. There's also for many countries, there's some limitation on specific details that provide our more detailed services, quality of the services. So there's an action needed, and a call has been already launched by WHO on trying to fulfill this, fill these gaps, data gaps, so that planning and budgeting can be informed and addressed. And as we said, there are some standardized questions that are already available that can be easily integrated into surveys, into existing monitoring systems without much difficulty and without extending too much existing surveys, but that can really provide some really important data for planning and budgeting. One example of an approach of progress on this has been in Uganda, where the Ministry of Health has worked with a number of sector stakeholders because they had identified a gap of information about WASH in healthcare facilities to integrate this in the health monitoring systems. This led to development of recommended indicators that have been validated and introduced into and agreed with MOH. And then these were introduced in the HMIS, in the Health Management Information System for data collection. But there's still some gaps there where we see that the data is still collected through paper-based and then inserted after onto the online database. So while progress has been made in integrating some of these indicators, we're still seeing that these processes are being very slow. In WaterAid, we've been trying to address this by supporting online use of ICT for remote monitoring and for collecting information through a digital tool. We've been using a tool which is called mWater because it's a free tool that is specific for the WASH sector, but can be used for any sector. And it's one that we have been able to train quite a large number of partners on. But it's just an example of a tool that can be used as many others. But what's important is that what we have done is created some we have inserted the standardized indicators that are existing from JMP, from WHO WASHFit tools into the mWater platform. And that means that because the tool is free for anyone to use, anyone can add the standardized indicators into any of their surveys. And then automatic data visualization is produced to provide this information. And so this is one approach that WaterAid has been introduced to support ICT-based kind of use to support WASH in health data availability. And we'll now hear a little bit more in detail the case study of Uganda that my colleague Ronald will present. So hopefully, Ronald, you can unmute and I'll go to your slide. Thank you.
Yeah, thank you so much, Helen, for that overview. My name is Ronald Obok. I work for WaterAid in Uganda as a quality assurance lead.
Can you speak closer to your microphone? Sorry, Ronald.
Can you hear me?
It's a bit low, but yes.
Okay, yeah, thank you so much. I will be presenting how we have used ICT, all those tools in Uganda to support the WASH in healthcare facility assessment, which we've done recently. But beginning with an overview of where this came from, it all started in the wake of COVID-19 when it was declared by WHO last year in January. And by March, Uganda had already got about 1,213 cases of positive cases of COVID-19. So when we discussed with the ministry, there are data gaps already that exist, but also the cases that had come by them were majorly coming from the truck drivers who are coming into the country through the border district. So as the Minister of Health, there was no clear assessment that was done to identify the gaps in the healthcare facility. So that data gap, which Helen alluded to earlier, was existing. So we worked with the Ministry of Health, especially the Environmental Health Department, the School of Public Health in Maternal, with Ministry of Health leading to develop WASH in healthcare facility assessment tools. So these tools were developed on M-Water, and when we identified the health assistants from the health facilities who are trained at the Ministry of Health and did the data collection in 54 healthcare facilities. The pictures you are seeing there were the state of some of these healthcare facilities and the border districts. You can see a latrine, which we have in a very deep hole there, but still was being used at the healthcare facility. So when you look at the incinerator, how waste was being managed and banned, it was really something which was serious. So the map on the right shows the facilities which will be visited at the border points, the district. Next slide, please. So upon collection of this data, we visualize this data on M-Water using the online interactive website dashboard, and the detailed report analysis was done by the School of Public Health, which highlighted the gaps in this WASH in healthcare facilities. If you look at on the right, those are some of the dashboards which showed 94% of the healthcare facilities having no presence of incinerator for infectious wash. And then only 10% of the healthcare facilities had latrines that were accessible and provided standard service levels at that particular moment. So this report was produced and findings disseminated by the Ministry of Health as part of the advocacy during the World Water Week. And this data has been used so far by WaterAid and other partners like Baylor Uganda to make sure that they fix and plan to bridge the gap in WASH interventions in border districts. Next slide, please. So how is the scale-up now done? Having done that in four border districts, the district of Tororo, where the border point of Malaba and Busia is, and then where the border point of Motopula and Ilega. So the Ministry of Health now, later with UNICEF, decided to scale up this countrywide assessment in 3,675 healthcare facilities. So this started by training as WaterAid. We trained the Ministry of Health as COTs, their staff, who later rolled out this assessment and monitored the supervision of data collection in 11 regions. And as I talk now, the Ministry of Health plans to use the sample tool which we have developed to collect data after every 3 years to assess the progress in all the healthcare facilities in the country. The picture on the right, the map on the right shows now what currently UNICEF is doing. And these are the facilities they have reached so far all over the country. And when you look at the green dots, shows now those are facilities with improved water supply. The red ones are unimproved water supply. So a click of button, someone can be able to trace which facilities don't have improved water supply. Next slide, please. So as I conclude now, how have we used this data to improve the WASH in healthcare? So the districts currently are now in their annual planning cycle, and they are integrating some of these recommendations which were in the report in their plans. And like I said, WaterAid has already gone with other partners to make sure that they bridge some of the gaps. The picture on the right there showing the before and after. The before one is one of the healthcare facilities in Eastern region, where that was a facility, a toilet and sanitation facility being used. But now the other one is what WaterAid later went and put in. And then what the incinerator, which was also put in one of the facilities by WaterAid and other partners. Next slide.
Great.
Yeah, thank you so much. Back to you, Helen.
Thank you so much, Ronald. As Ronald was explaining, we've seen an example of where by creating a standardized survey that collects information on WASH in healthcare facility, it was possible to mobilitate funding to also support and address some of the gaps of services and to really share the information with the sector. So this is really a key way of leveraging ICT to really support data availability and leveraging changes in the WASH access in healthcare facilities. Zambia has done similar work by using, again, mWater to create a similar survey across a smaller number of healthcare facilities, but it's also looking at scaling up. And at the moment, the survey the data that's been collected has been really adopted by a number of different NGOs and is really useful to inform about where new intervention needs to be focused on. And it provides similar indicators about type of water accessible, the continuity of water supply, type of latrines, type of waste management, and rotas for cleaning the healthcare facilities. So all key indicators for addressing environmental care. So in the future, we're also looking at, we're working already on some existing, so how to improve planning processes based on this data that's been collected. And some tools have been created on Excel that can support budgeting processes, where data from these monitoring processes can be inputted and provide long-term budgets and costing. So different financial models can be developed. This is something that is work that we are looking at also integrating and automatize. So very keen to learn from others in the sector. If something similar already happens in health, how can we integrate some of this data into health financial modelings as well? So we're going to leave you with hopefully some inspiration, but also some questions about what happens already in other countries. How are health MIS systems integrating WASH, waste, and environmental cleanliness indicators? And then some questions about how can WASH data be better integrated in health quality improvements processes? And then how can we really support also using WASH data and community health data to target intervention and investment? And if there are any other platforms on top of the HMIS where WASH data needs to be integrated into. So these are our key continuing questions to continue this work of integrating WASH and the 5 areas in health management information systems so that improvements can be sought. Thank you very much for the attention and welcome any questions.
Thank you, Mr. Ellen Greggio. Sorry, Madam Ellen Greggio. Thank you, great presenters, for the great presentations you've made to the audience. Allow me to give only one question because time is running. If there is any, then we'll have to close this session. If there is any question from the audience, we'll take one quick question. Because we have not much time, I'll not delay the questioning part. I'll allow my panelists to close, give their remarks, their last remarks in just seconds, not even a minute, because we're running out of time. Thank you.
My take-home message is that digitalized health will be saving lives. Thank you.
Thank you very much, Muhammad, Mr. Dino. If Mr. Jason is still online, then we'll hear from him after Mr. Dino.
Hello. I just have a question for my colleague from Zipline. On your slide, when you showed that for 2021, you have an exponential growth of your sales, is it due to COVID pandemic?
So we can see that most of the deliveries actually were done within 2020 and 2021. That was the period between COVID. So I think it was COVID.
Mr.
So,
Seneca?
yes, my take-home message would be we need to come together as one entity and then provide equitable healthcare to patients at the comfort of their vicinity or homes. And that is what Zipline is fighting to do. And we need the help of each and everybody.
Thank you very, very much, great panelists. Thank you, audience, for your patience to listen to us. And indeed, it is our assignment all as the global citizens to ensure that we are helping the healthcare. Jason is online. Jason, do you have a take-home message for the audience? And Gwen?
Yes. Clearly, everyone who's presented in this panel is rapidly building multiple integrated connected health ecosystems. I'm excited to do more work in Africa and begin collaborating with all of you. So I just think there's a lot to applaud and be excited about. Thank you.
Thank you, Mr. Jason. With this, I take this opportunity to thank Beast Seal Investment for organizing this global summit. I take this opportunity also to appreciate most of our partners that I see here present. Annabelle has been in this digital health journey with us, Rwanda in particular, in building the digital health tools that you've had, the integration of the systems that we've been talking about, where we did a project with them that is called Kigali Health Network, and other projects that we've done with them. I see Zipline, I see many partners that we've partnered with. Even RBC. RBC has, RBC is our implementing agency. It is our implementing arm. And without the Rwanda Biomedical Center, the Ministry of Health couldn't be implementing all these initiatives without the implementing hand. I take this opportunity to appreciate our master of ceremony, who has done a very great job, and everyone who has participated. Just my take home is that our wish is that if I traveled to any country on the continent and my test still has the validity, let's say if there's a timeline of 7 days and those days has not expired, I shouldn't be asked to take another test because I've reached another country. The integration is clearly needed so that we have access to intercontinental systems, countries' systems, and be sure to build the trust amongst ourselves so that if I've been tested in Rwanda, if I go to South Africa in 3 days, I'll not be asked to be tested again because they have access, we've integrated our systems, and they have visibility of all the indicators that we've chosen to share. So the global integration is key. We've started that journey, and I believe it's a journey that we should continue, mostly as Africans, mostly as the global citizens, to ensure that we share most of the services. If a drug has been banned in Nigeria, in the US, I should have a visibility of that counterfeit and be sure that it is limited at our point of entry in the country and it is not administered by my patients or by my citizens. This is a journey, a patient journey, where we'll improve the patient experience, where our citizens will have access to their health information, will have easy access to their doctors, to their nurses, and be able to revisit their results whenever they want to, they feel like. And this is a journey that does not require only the health sector, does not require the ICT sector, but all citizens to partake, because to attain that, it requires financial sustainability, it requires a mindset change for the citizens, the culture to embrace the digital transformation is a requirement also to the citizen. Thank you very much for your kind attention and attending. Thank you.
Thank you very much, Engineer Edith Munyana. A round of applause for our moderator and panelists. Please, But before you leave, I had a question, and actually perhaps a comment. I have been very, very encouraged by the presentations of today. I've been very, very educated. And I'm thinking, how can we, I think either Professor Dr. Jason or one of our colleagues here spoke about that, the integration, not just in health, but even across all the sectors of development. And I'm looking at how the mobile money, mobile money and banking has integrated. You can go to any country and use your ATM card for any bank, and it can work. So how can we use the developments in the health sector around digitalization and those platforms to impact our social development other social development sectors? I think it's a big question. Not a question that we can answer today, but a question that I'd like us to continue thinking about, and then perhaps next year when we meet at the Global Healthcare Summit, we may have some answers. So thank you very much, Engineer Edith. Thank you very much, dear panelists. Dr. Jason, Ellen, thank you all very, very much. Well, have a wonderful evening and see you all tomorrow. Thank you very much, audience. You've been very, very patient. Thank you. Have a wonderful evening. Bye-bye.